Good afternoon, everyone. It is our pleasure to start this session about free papers, and it is really my honor to be here with my friend and colleague, Dr. Taskin. Of course, we would like to remind you to stay in time. This is the last session of the day. We are all very tired. We are all also very interested in your discussions, so please be scientifically quick. Thank you very much, and it is my pleasure again to introduce Dr. Claudia Leslie from Germany. She will present about metabolic surgery reduces CRC disease progression through circulating bile acid diversion.
So thank you for the nice introduction and welcome to the last session. I have no conflicts of interest, and I would like to begin this basic science presentation with a clinical outview. And this was a systematic review and meta-analysis from the year 2023, and it compared obese patients with bariatric surgery with patients who did not bariatric surgery. And the first endpoint was the cancer-associated mortality. And if you can see on this graph, after metabolic bariatric surgery, they had a risk reduction of 50% to die on cancer. I mean, when you focus on this data on the colorectal cancer incidence, you see as well that you have a reduction of nearly 50% to get a colorectal cancer after metabolic bariatric surgery. And I saw this data years ago in other studies, and I said, okay, what's on this impressive clinical effects? What's the driving factors under this clinical effect? And then I tried, or I decided to intervent a mouse model which combined metabolic bariatric surgery with a common colorectal carcinoma model. And I just made the obesity model with a high-fat diet, just feeding the mice 6 weeks high-fat diet. Then operated them with a classical Roux-Y gastric bypass. And after a metabolic adaptation of 6 weeks, so the Roux-IGB mice lost weight, I implanted then living colorectal carcinoma cells, so tumor organoids, under the subserosa of the cecum. And another 6 weeks later, I looked at the mice with tumor growth and liver metastasis. So this colorectal carcinoma model, this is really closely mimics the human situation in the carcinogenesis and metastasis, and is at the moment one of the best mouse models. So now let's look at the results. After 6 weeks after tumor transplantation, you see that the gastric bypass mice had significantly lower tumor burden, so lower tumor volume, and I was really so surprised to see this at the first time, that I had no liver metastasis, whereas the high-fat diet group, the sham operated group, had a lot of liver metastasis. And looking now at these striking results, it naturally leads to the question, okay, what's going on there? What drives this effect on the cell under these phenotypes? And now I'm going a little bit ahead because of the time. So I looked at these typical oncological effects, tumor microenvironment, microbiome shift, all these things, and nothing seems to be significantly between these two groups in my model. And then I remembered me on the bile acid shift. So I asked me, okay, what happened when I just diverted the bile with a normal food passage? And this is good at mouse models. You can just try it. So it's not like in humans. So I just intervened another operation with a isolated bile diversion. So I ligated the main bile duct and made an anastomosis between the gallbladder and the jejunum at the position of the JJ anastomosis. So in this model, I have just a bile diversion with a normal food passage. And can you now imagine what happens next with my tumors? I had the same effects as after the gastric bypass operation. And now my new hypothesis was that the altered bile circulation in the gastrointestinal tract induced by gastric bypass or like this gallbladder operation plays the major role in the impairing the colorectal cancer, carcinogenesis, and metastasis. And as we all know, is that afterwards bypass, there's a shift in the bile acid composition in the blood. And specifically, we know from human studies as well that the primary bile acids lowers, whereas the secondary bile acids getting higher levels. And this was confirmed in my analysis of the mouse blood as well. And as you see, we had the same bile acid levels and the same bile acid composition with the gallbladder operation. And the next step is with this, after this basic science, that what about in humans? So can we transfer this insights into the human situation? And I collected a human cohort. It's patients with UECC stage 4 colorectal cancer, and they all had metachronous liver metastasis. And then I looked in the blood serum and divided them into two groups. One group with lower primary bile acids, and the second group with higher primary bile acids. And when you look now at a metastasis-free period, you see that patients with lower primary bile acids, also like in the bypass group or like in the gallbladder group, they had a significantly longer metastasis-free survival from the liver metastasis as the patient with higher primary bile acids. So we can see these effects from the mouse model as well as in our human cohort. And now to then I was interested in, okay, what happens in the cell? So what happens on the RNA level, on the protein in the cell, on the working on the single cell? And then I incubated murine and human colorectal cancer cells with a co-incubation with primary bile acids. I just looked, okay, I just gave some primary bile acids into the Petri plate as well. And you see here on the right side, also yellow is upregulated, that in the cancer cell, when I give them primary bile acid, all the signal pathways for stem cells, proliferation, metastasis, initiation, they were upregulated. So the bypass surgery leads in the single cell on RNA level, on the lowest level, to an upregulation of the pro-metastatic and pro-carcinogenesis effect. And now, a short summary of my data is I was able to identify in this mouse model the one key factor from the bile acid alteration as a significant role in the carcinogenesis and metastasis. And this key factor is just one factor around multiple factors which are in the metabolic reshapement. But I'm convinced that approaches like this will become increasingly important into the field of the oncology in the future, and maybe helping shedding light to these complex processes under these multiple metabolic effects after bypass surgery. Then thank you for your attention. Hello.
Thank you very much, Dr. Leslie, for your presentation. I have a question.
Yeah.
We have a lot of evidence that are demonstrating that after bariatric surgery you can have a reduction in the incidence of different kind of cancers, like breast cancers or uterine cancer. But we have conflicting results about the colorectal cancer. I mean, there are some meta-analyses showing that you can have a high incidence of colon cancer after bariatric surgery, and the reason is that you have a high rate of bile acids going into the colon. So how do you explain this?
So which studies do you mean? So at the first time it was about 2010, 2012, there were several case reports about higher dysplasia in the rectum after metabolic bariatric surgery. But when you look at the first meta-analysis. The first one was in 2013. Then since then, it's just reported that you have a lower colorectal cancer incidence.
I've done a research on this topic for the IFSO because we wanted to do a position statement that has never seen the light. But I remember that there were conflicting evidence about the colorectal cancer.
Yeah, but I think
some studies that were demonstrating that you had no high incidence of rectal cancer, but high incidence of colon cancer. So I'm just asking, what do you think of their explanation? Because they say you have a high rate of bile acids going into the colon with the bypass, not with the sleeve. Because with the sleeve, they didn't find any kind of high incidence of colon cancer after surgery.
I first thought I was so my first step was to think about the microbiome change. I said, okay, the microbiome maybe makes this traumatic effects, but I couldn't see a shift in the microbiome in the cecum, but I couldn't see a shift in the microbiome in the tumor. So you have to look the bacteria from the colorectal cancer in the cecum. They take the microbiome to the liver metastasis, to the liver. And there I didn't see a difference. So the microbiome migration into the portal vein, into the liver metastasis, there were no significant differences between bypass and no bypass group.
Okay, thank you. Is there any question from the floor? Please. Yeah, with Mike, it's better.
Hi, Claudia. Really nice work. Yeah,
Thank
really
you.
nice work. My question about here, I was thinking in the beginning when you was trying to explain your experience. I was thinking that we will find the difference in the secondary biliary acids, not the primary ones. Did you separate the primary? You use the cholic and chenocholic acids. Were those the primary biliary acids that you use, or do they have any kind of differentiated?
I don't
understand. Sorry, no worries. Secondary biliary acids has a potential to especially be using the TGR5 receptor, has anti-inflammatory one, has a hormonal effect. So I was thinking that probably the secondary biliary acids would have any kind of how do we say it? Would have any kind of difference in the evolution of cancer. But what you found was on the primary ones.
No, I made this analysis with secondary bile acids as well, and because of the time, I just showed you the picture with the different of the primary bile acids, and the secondary bile acids. There was no differences in the metastasis-free survival in the patients. Okay. So yeah, I thought as well it's the secondary bile acids because they are microbiome connected.
Yeah.
But yeah.
And then in the primary biliary acids, there are both two, cholic and chenocholic. Yeah. Do you differentiate it on your work?
Yes, I differentiate.
Was there any difference, or was both of them?
Yeah, this slide I removed yesterday evening because of the time. Yes, I made different bile acids and these bile acids in different concentrations. Okay. And I had the same effect, so I can show it on my handy.
Both biliary, with the cholic and the chenocholic, they were both giving the same effect, the same solution.
Yeah, on the primary bile acids. The primary bile acids, they had the same effect, so I can show it on my handy.
Thank you very much. Brilliant work. Thank you very much again.
Thanks for this interesting presentation. Now we have Dr. Luis Osaña Gonzalez, and he's going to present us impact of skeletal muscle mass on the severity of metabolic-associated steatotic liver disease in severely obese patients.
Good afternoon. Thank you to the moderators. We are going to talk about what's the matter with the liver if we compare with the skeletal mass. Nothing to disclose. We start talking about NAFLD close the 80 years in the past century, but this terminology does not accurately capture the true etiology, and also use one terminology, stigmatizing fat. That's the reason in 2020, Islam et al. Changed the terminology talking about MAFLD. They start talking about not only change the nomenclature, but also the definition of the disease, but it's not still the clear association with the problem we really have. Now, till 2023, we are talking about metabolic associated steatotic liver disease. It's more clear, and it's talking about the same disease as diabetes, hypertension, everything happens in the people living with obesity is here in this terminology. And all the principal papers about the pathology and the association studying the liver start using this terminology we are using today. This is the worldwide distribution of the disease. As you can see, it's very, very, very common in Europe, also North and South America, Middle East, China, India, and also Australia. This is the evolution of this disease. You can think about, okay, it's a long time evolution, so it's a disease for elder people, so it doesn't matter, it's not important disease. Okay, important disease for elder people is absolutely important, but okay, you can think about it's a long time evolution. But now we have this problem, we have people, also children and adolescents with a big, big, big problem of adiposity and obesity. You only have to wait more 20 or 30 years. So when they are close to 50 years, they have some percentage, 10 or 50% with cirrhosis, with bad evolution of this cirrhosis, also with hepatocarcinoma in this age, and some of them is going to be the reason of their death, and also they need a liver transplantation. What's the problem? There is no liver for everybody. At the same time, the evolution, I am talking in this Congress and hearing my colleagues about after 30 years career, professional career, we are seeing the evolution in our disease. 30 years ago, we was worried about the patient lose weight. Okay, that's all. 20 years ago, Francesco Rubino started talking about metabolic surgery, and we was very impressed, like now cardiologists and endocrinologists with the new drugs. Okay, they are now without diabetes, without hypertension. They don't need the machine to breathe during the night for sleep apnea, dyslipidemia. But now we are in another step. We are more ambitious, and we are talking about the BNI is not enough to describe this patient. So we are making impedantiometry. We are taking a look about the morphofunctional study. Our colleagues in our multidisciplinary team explain us how to do it. And that's the reason the skeletal muscular mass is very important to describe this patient. Every patient is an individual patient. So, looking at this background, we are going to try to see what's the matter with the link between skeletal muscular mass and the levels of severity of muscle D. So the question we make, talking about objectives, is does reduces muscle mass activity dictate the progression of severity of muscle D? As you know, severe obesity is usually have a link with the bad evolution of the liver disease. And at the same time, muscle is a primary driver of the problem with insulin and metabolic driver in our patients. So we're going to try to associate both. This is a cross-sectional study including 72 individuals classified based on skeletal muscular mass in two levels. 0 is normal muscle mass and 1 is low muscle mass. And muscle D was classified into 3 categories. 1 is no steatosis, 2 is muscle D, and 3 is MASH, metabolic associated steatohepatitis. Okay, a contingency table we use to distribute on the muscle D and skeletal muscle mass groups, and Fisher-Stark test was applied to assess the statistical significance. How about the results? In these 74 patients, we 100% presented with obesity, so high BMI and 30, and sarcopenia risk. Low muscle mass was observed in more than 70% of the population, demonstrating the high prevalence of that. Despite this, we have a surprise because the sarcopenic obesity, you think, maybe you are thinking previous to see the result, okay, it's going to be so high. It's just the 4.5% of the participants, while dinapenia, the reduced hand grip strength, was also identified the same level, 4.5%. High fat mass was present in 92% of individuals, indicating a predominant adiposity profile. Functional performance assessment showing limited capacity. It's very interesting to take a look. Only 3% of our patients have criteria for the 30-second share stand test. you have to ask the patient to stand and sit during 30 minutes. Depending the time he's going to do it, he's going to be inside the group or not. Just 3% of the patients are inside with this criteria. And also just 1.9% for this patient have the 5 sit to sit test in this case. This is the table, more important in this study. As you can see, we classify the muscle D, as you know, grade 1, 2, or 3, and muscle mass 0 and 1. It depends, is normal or low. You can see grade 3, 30 patients have low muscle mass, so just 2 have normal muscle mass. So this is the more important thing and the significance of this. We have a vicious cycle of hepatic and compositional decline. The muscle mass, the muscle liver axis is important because you go from severe obesity to muscle depletion to liver progression and finally functional decline. In conclusion, low muscle mass is significantly associated with greater severity of muscle D in individuals living with obesity. This finding highlights the importance of assessing muscle mass to better understand and manage metabolic risk in this population. I am so proud about my clinical and also my research team. Thank you.
Thank you very much. Are there any questions relating this study? I have one question. I think these patients also have very high fat mass because they have low muscle mass, and their adipokine levels also are lower than the other population. So do you think that also this has a huge impact on this MASH incidence in these patients?
Are you talking about the MASH in the liver?
Yes, yes.
Definitely. We have no doubt. Since the last, I think, 10 or 12 years, we are taking biopsy of all of our patients, and we are sending to departments, to the basic researcher and also to the pathology, and we are comparing both. Definitely, we are discovering, not only when you start the surgery and you see a cirrhotic liver, you don't expect you are going to find there. No, I'm talking about all the patients with a quite steatotic liver. We are seeing maybe MASH and also fibrotic liver, not maybe 4, not cirrhotic, but maybe 2 or 3 fibrosis is so important. Yes, I have a relation between the fat mass and MASH, definitely.
Thank you. Thank you very much.
Okay, thank you.
I'm going to introduce Anna Casajana, who is an active member also of the Young IFSO group, and she's going to talk us about a new tool for training assessment in metabolic surgery. Thank you very much.
Yeah, thank you. This is true that this is nothing related with liver, but there's always some presentation that it's in another session with a different topic, but I hope you enjoy about this because I think it's so useful for everybody, for the training surgeons that are here and for the people who normally attend trainers. So I am from a university hospital, and when I arrived there, I was so preoccupied because our residents were not motivated because they had the sensation that we don't help them properly, to perform procedures, to show how they develop procedures. So we designed it a digital tool to improve this. So I have no disclosure, and it was because the accreditation system in general surgery resident training in Spain, it's so old. It's from 2007, so it's more than 10 years, 15 years, so the things change a lot. And this system, it's based just in the number of surgeries and on the type of recommended procedures, and then based on a final rotation score and the subjective assessment of one professional per rotation. So this is how here in Spain we evaluate the surgical residents. So I think it's not enough. So when you look outside, you start to see that different countries have more solid systems to evaluate, to motivate our training residents. So we see that UK, Canada, USA have programs that evaluate the resident, dividing the procedures through steps, and evaluate the different steps, from different point of view, the perception, the skills, so it's more complex than our systems. So to improve this Spanish system, we developed a digital tool named TROM. This is that we register the patent, the patent of TROM because it's not exist. It's like the PROM, but in training environment. So it's named Training Reported Outcomes Measure, and it's for real-time evaluation of surgical procedures based on a step-by-step assessment, resident self-perception, and attending a feedback between the attending and the resident. So we hypothesize that this approach probably improved training quality, increase attending involvement, and enhance understanding of residents' performance and their perception about this. So for that, we decided to evaluate the first preliminary results, and we evaluate the perceived number of procedural steps, their level of completion, and agreement between the attending surgeons and residents. We always compare, if the look that we see, each step, each procedure, the knowledge, and the autonomy, it's match or not match. Okay, so in this sense, we developed finally, after more than 1 year deciding which digital tool use, finally we decided to organize an easy REDCap, with a web app that we can have with the REDCap. We create the patent, of course, and after we create the structured questionnaire to evaluate these two domains. Per one hand, analyze the quantity of steps in each procedure, and if the perception of the resident and the attending surgeon is matched or not. So if the step is complete, partial, not performed, or not candidate for this procedure. And then we develop, based in the Canada and States, and the UK evaluation questionnaire. So we developed this easy questionnaire to evaluate the autonomy and the knowledge of the resident with a numeric rating scale between 0 and 10. So it was a general surgery service project. So each department have these different questionnaires. Okay, and for our unit, we decided to include just the primary cases of bariatric surgery, gastric bypass, sleeve gastrectomy, and in case of oncology, partial total gastrectomy, GERD procedures, and exploratory laparoscopy. So we divided each procedure in 5 steps, and then we developed the other questionnaire. So with that, the analysis was after the resident and the surgeon answered the question. So we correlate the total number that we achieve from the different questionnaires to see if the resident underestimate or not the procedure that they perform. And this was the main objective, to see. So we were 3 surgeons, and we include 6 residents between the 3rd and the 5th year. And the number of procedures we incorporate in these preliminary results, it's just 63. It's not a good outcome. I think it was not systematic, registered after each procedure, but I think that the interesting thing about these 63 registered procedures from 202 eligible procedures during 2 years, so it's that it was not systematic, and the nice thing to see is that after we start this project, we started to help more the residents, because we started like a competence between the different units, within the surgeons, to see, okay, you help more, you don't help the residents. So this motivates to all the service to encourage to help more the residents. So during the first year, we registered that we had just 22% of procedures of our unit, and then if you see the second year, so we increased to 34. So, and I think here in red you see that the next years probably we will continue helping more and more, because these are not a good outcomes. So I think this is the main conclusion for us to motivate to improve this, because we are a university hospital, and it's our work to help residents to gain knowledge. So when we see the results about the procedural steps, here the result is that resident tended to underestimate about the step completion. So here the surgeon said that, okay, I help you a lot performing, and I give you all the skills to do all the steps, but the resident thought that he doesn't perform all the steps. So I think this point of view, it's need to be analyzed between both. And when we see about the evaluation, knowledge, autonomy, it's the same. The resident tends to underestimate their knowledge despite overall good agreement. So I think we need to improve in case of our hospital, the resident has a good skills, knowledge, and I think we need to improve this thing because it's not good, the outcomes that we've had. So the conclusions is that the procedures involving residents are increasing in our unit, and the adherence registering the procedures helps engage attending surgeons more actively in resident training. And regarding the procedural steps completion, we had low moderate agreement, so residents tending to underestimate, and regarding our knowledge and autonomy is the same. So for us, the two main conclusions is that we need to help more the resident, more and more. We need to register to have this data, to be conscious about it. And of course, we need to encourage them to have more estimate. Okay, that's all. So thank you here. We are all the team of the residents, so we are proud about this. It's not good outcomes, but I think we need to present the good and the not good outcomes to be more conscious about the reality.
Gracias for your presentation, and I have two questions. The first one, maybe you have already answered with this picture, because I saw the previous picture and I was asking, is your hospital on the beach? Because I saw, but it is. Second question, a serious question. Of course, in this study, you have evaluated that the residents, they underestimate their training, but you are, comparing their feedback and your feedback as an attending. Maybe you are overestimating, maybe you need a third,
Could be.
a third person, a third, researcher,
I think we need to think, because this is true. Maybe it's the opposite, But we always think that we know.
I'm just suggesting maybe if you, continue the study, you can add
but what we see is the residents on the third year underestimate more. And then when they are higher level, they overestimate. So I not introduce all the things because we have only 63 procedures. I think we need more data.
You need someone who is not in training, not the trainee, not the person who is training them. Someone, some other surgeon in the room, maybe attesting the kind of autonomy of the.
We have
the
more
trainee.
than 1,000 data now with all the service, so I think next year we will present with more data.
Thank you. Is there any question from the floor? So thank you very much again, Anna.
Okay, our next speaker is Dr. Tadeja Pintar from Slovenia, and she's going to present compensatory mechanism of circulation and interpretation of liver function, predictive factors from MASLD, earlier therapeutic management.
So good afternoon. We are continuously searching for a non-invasive testing for liver ability or inability in patients with metabolic disease underwent metabolic and bariatric surgery due to increasing burden of obesity. Dynamic liver function tests allow, as we all know, assessment of liver ability to metabolize substances over time. And unlike static markers, they are based on clearance of compounds. They are metabolized almost in the liver. This allows a direct and quantitative assessment of liver function. Hepatic clearance depends mostly on the blood flow through the liver in the normal circumstances without liver pathology, and the liver's extraction capacity is described by the presented equation. When the liver extraction capacity is high, clearance is mostly dependent to the liver blood flow, but in pathologic circumstances, when extraction is low, it becomes dependent to metabolic capacity of the hepatocytes. For this idea, we approached to the study to test the liver capacity with indocyanin green clearance, that is a dynamic method assessing liver function. And using this reflects hepatic clearance as a function of hepatic blood flow, and taking into the account that following intravenous administration, indocyanin green concentration can be measured by pulse oximetry or color densitometry. The measurement or dilution cure shows an initial peak up and bolus administration, and the secondary peak, like presented in the slide, during systemic recirculation or redistribution, and eliminating phase, reflecting and excretion ability to ICG liver function. From this point of view, we prepared the study. Included 77 patients underwent bariatric and metabolic surgery, controlled with 24 patients underwent programmed laparoscopic cholecystectomy. In all groups, all anthropometric and blood tests were performed, including non-invasive and possible calculated liver tests. And intraoperatively to all patients, we performed wedge liver biopsy, underwent Kleiner classification. In the same cohort of patients, the day of surgery, just before surgery, the patients, we performed indocyanin testing. We started with three hypotheses. The first, ICG clearance, is associated with metabolically associated fatty liver disease. The second one, the clearance is associated with resting cardiac function. And the third one, that clearance is associated with non-invasive markers of muscle and the patient's metabolic status. So the first hypothesis was confirmed. We showed statistical significance with uptake and secretion ability of the liver that was significantly lower in the patients underwent metabolic and bariatric surgery with both PDR uptake and excretion ability of the liver. So the first hypothesis was positive to our prediction model. And going to the second hypothesis, that ICG clearance is associated with resting cardiac function. After introducing all other data, we confirmed that minute volume, cardiac index, and diastolic blood pressure are significantly important for excretion liver function, both uptake and the second phase of the testing with ICG. We performed then the correlation was statistically significant with the calculated constant 0.1. Going through the idea, we found that, like I mentioned, minute volume, cardiac index, and diastolic blood pressure are the most important variables regarding the cardiac function, all tested with posterior predictive check in both testing groups. The third hypothesis was that ICG clearance is associated with non-invasive markers for muscle and the patient's metabolic status. The linear regression model was positive for three variables: cardiac index, ICG clearance, and gamma GT. And for multivariate analysis, revealed that the most important factor was ICG clearance that was suppressed by the other covariables in the linear model. So we can conclude that also this hypothesis was confirmed. Then about NAFLD fibrosis score, the Spearman test was positive with a statistically important constant, and how we are able, based to all the parameters, also conclude ROC analysis was significant with guidance coefficient 1.2 that reveal good or optimal sensitivity and specificity of the tests and correlations. Coming to the results, PDR was significantly associated with pathological histological score. Indocyanine green clearance was significantly lower in the observed patients underwent metabolic and bariatric surgery compared to the controls. Cardiac output and cardiac index independently associated with R15. This is the excretion time, and adjusted for cardiac output, cardiac index significantly correlated to the liver fibrosis grade. In conclusions, indocyanine green clearance reflects muscle severity in metabolic bariatric patients in our cohort of patients. Its diagnostic value is further enhanced by adjusting for cardiac function. This novel approach may be, of course, with further studies. This is a small group. We are very aware of this. May improve non-invasive assessment of muscle, then supported treatment individualization in patients preparing for metabolic and bariatric surgery, or in general for detecting risk patients and progression to higher grades of liver fibrosis in obese patients. Thank you very much.
Thank you very much for this presentation. Are there any questions? Do you think that it's more, this clearance test is economically feasible to
Yes, it's very cheap for a single patient and is easy reproducible. We also tend to test year after bariatric and metabolic surgery in the same cohort of patients.
Okay, thank you very much.
You're welcome.
And I cannot wait now to listen to Dr. Maria del Carmen Martinez Bagant and her presentation about audit or outcomes in robotic metabolic bariatric surgery. Please.
Hello, thank you for your introduction. I'm going to talk about the audit of outcomes in robotic metabolic bariatric surgery, a benchmarking and textbook outcomes analysis. We see that the interest in scientific societies in improving surgical quality is increasing. We can see in this slide the number of publications on this topic has grown in the recent years. But how do we measure this quality? We use clear indicators that let us review our own results and let us compare them with the ones to the other centers. For this, we have used the strategy of benchmarking and textbook outcomes. Benchmarking or comparative evaluation is a tool for improving outcomes. It represents the cutoff point of the best possible result. The difference between your actual results and this cutoff point shows the theoretical potential for improvement. And how do we calculate the reference levels? Well, we select centers with a high number of cases, our reference centers, and then we select the benchmark patients, that they were the low-risk profile of patients. We analyzed clinically relevant variables and we obtained the median for each variable in each hospital. And then from this median, we obtained the 75th percentile. And this is what we name the reference value. If our outcome is below it, we have a favorable result, and if it is above it, we are in the improvement area. By the other hand, the textbook outcomes are compound indicators, and they represent an optimal outcome. All the criteria must be met to be considered as a textbook outcome. We use specific variables that were described in this article in 2023, and they were not having a major complications according to the Clavian-Dindo classification, no prolonged hospital stay, no death at 30 days, and no readmission in 30 days. To summarize, benchmarking lets us compare our own results with the ones or referral centers, and is like an external audit. And textbook outcomes, meanwhile, are a compound indicators that helps us to evaluate our own results. We have two objectives that were to evaluate, after implementing robotic bariatric surgery in our center, if we met the international standards, comparing our results to the ones obtained by the reference centers using the benchmarking strategy. And second, to evaluate whether our outcomes improve after implementing robotic bariatric surgery compared to the outcomes obtained by laparoscopic bariatric surgery from the perspective of textbook outcomes. We include all the primary bariatric surgeries made between January 2022 and August 2025. And they were the bypass, gastric bypass and sleeve gastrectomy. And we introduced the robotic bariatric surgery in January 2024. And after that, all the surgeries were made only by a robotic system, UGORAS. This is a descriptive and retrospective study with two groups. First, we compare the results of our benchmark cases in robotic bariatric surgery in our center with the ones of the reference values. And a second part, we also compare our own textbook outcomes in robotic bariatric surgery with the textbook outcomes in laparoscopic surgery. For the first part, we select our benchmark cases that were all the patients that met all these criteria: age between 18 and 60 years, ASAA less than 4, a preoperative BMI less than or equal 50, and no high-risk criteria. If only one of these variables or multiple variables wasn't met, the patients were classified as a no benchmark or high-risk cases. We use perioperative variables, a 90-day morbidity and mortality variables, and specific complications at 90 days. For the results in the first part, we had 103 patients undergoing robotic surgery. 80% of them were gastric bypass. In both groups, gastric bypass and sleeve, there were more high-risk patients, and only the 25% in gastric bypass and the 90% in sleeve were benchmark cases. Most of the patients were women. The age range between 42 and 51 years, with a perioperative BMI between 42 and 49, and most of them had an ASAA score of 2. When we analyze the perioperative variables, we see that all of them were below the reference level, which is a positive outcome, with no need of conversions or blood transfusions. The length of stay was in both groups less than 2 days, and we had no readmissions at 90 days. Again, we stay below the reference levels in morbidity and mortality variables in both groups of benchmark cases, and we also stay below the reference levels in specific complications at 90 days in benchmark cases. This study was initially designed to assess only the low-risk patients. However, we later expanded to the analysis to include the high-risk patients as well. And then we see that in the high-risk gastric bypass, we also stay below the reference levels in all the variables studied, but in the high-risk sleeve group, we had one patient that has an upper gastrointestinal bleeding, which resolved without further intervention, but that same patient was readmitted due to an anastomotic leak, requiring gastroscopies and antibiotics. So we are in these variables above the reference level, so we are in the improvement area. For the study of textbook outcomes, we had 119 patients undergoing laparoscopic bariatric surgery. The 71% of them were gastric bypass, and mostly were women, and same characteristics that they occurred before of robotic bariatric surgery. And we saw that we achieved higher rate of textbook outcomes in robotic than laparoscopic surgery, with a 93% in robotic and 86.6% in laparoscopic. In the graphics, we can see how the variables that define a textbook outcome and which ones were the most relevant to achieving it. And the factor that most influenced it to not achieve a textbook outcome was prolonged hospital stay in both groups. If we analyze this by the type of surgery in gastric bypass, we see that also we had at higher textbook outcomes in robotic surgery than laparoscopic surgery. And if we see the sleeve gastrectomy, we see that we had an 86.4% of textbook outcomes in robotic surgery over the 73.5% in laparoscopic surgery. And we see that in the laparoscopic group, the prolonged hospital stay was more evident than in the other groups. So, in conclusion, after evaluating outcomes using benchmarking, we met internationally described reference standards. From the textbook outcomes perspective, our center has improved results after implementing robotic bariatric surgery. And textbook outcomes and benchmarking are useful tools for evaluating surgical results. Thank you.
I want to congratulate with you because I think this is a very good study, it's a very good way to make an audit. And so the result is that you are performing better with the robot than with laparoscopy. Is that correct?
The objective of this study was not to say
your,
that robot is better than
your
laparoscopic.
results were more comparable to the robotic benchmarks than to the laparoscopic benchmarks.
We first went to audit the results of the robot because it was the last thing we implemented in the hospital, and then we add the textbook outcomes analysis.
Are you doing hybrid procedures? Are you using the stapler? I think you're using Ugoras. So I mean, you're using their stapler, the Signia.
Sorry, can you repeat?
Are you using the Signia stapler?
Yes.
Okay, so they are hybrid procedures. They are not full robotic procedures.
At first, we didn't have in the Ugoras doesn't have the energy. So at first, we had a surgeon that was helping the first surgeon, but now we have it, so it's only robotic.
Yes, I was asking this because you had one bleeding from the sleeve group and also one leak, but they are not relating to the robot because you were using laparoscopic staplers.
Yeah, it was one of the first
because
cases.
This is confusing, in many papers they say we have higher complications in the robotic sleeves, but many times they're doing hybrid procedures, they are using the laparoscopic stapler. So
yes.
Is there any question from the floor? Thank you very much again.
Thank you.
Our next presenter is Dr. Albert Caballero Boza from Spain, and is he not coming? Okay, then next presenter is Dr. Carlota Tuero Ojanguren from Spain. Is she here? Okay. Changes in ghrelin concentrations and adipose tissue in rats with diet-induced obesity after sleeve gastrectomy, one anastomosis gastric bypass, and single anastomosis duodenal switch.
Good afternoon. I have nothing to disclose. So obesity is a multifactorial disease, and energy balance results as a complex equilibrium influenced by multiple factors, ranging from genetic and epigenetic to environmental aspects, including also nutrition, physical activity, and involving also the neuroendocrine system. The benefits of metabolic and bariatric surgery extend beyond weight loss and are also associated with hormonal changes when ghrelin takes a major role, and also with adipose tissue remodeling. So to investigate these changes, we perform 2 experimental animal models, and this approach allows us to make direct and specific control interventions to dissect the underlying mechanisms of the surgery. The aim of the first study was to evaluate the hypoabsorptive effect. So we compare a primarily hypoabsorptive procedure like OAGVP with another group of rats with caloric restriction. The experimental design included 40 male Wistar rats that were fed with a high-fat diet, 34 of them, for 16 weeks. After that, they were randomized into receive OAGVP, another group that received sham surgery to discriminate surgical stress, and another group of rats that were received a perfect diet that received the same amount of food as the surgery group. 4 weeks after the randomization, rats were sacrificed and we extracted adipose tissue, blood samples, and also measured the energy expenditure. Body weight, as we can observe in the first graph, was more higher and more maintained in the OAGVP group, and this was also consistent with the total adiposity fat depots. At the histological level, adiposits in the rats intervened of OAGVP were smaller, and this was also accompanied with a lower quantity of leptin and also adipo index. This everything suggests that this group of rats, the adiposit of this group of rats are more insulinosensitive than the other 2 groups. Regarding the food intake, relative food intake was similar between the 3 groups, but food efficiency ratio was significantly lower in the OAGVP group. To get a deeper insight into these findings, we also measured the rectal temperature and also the interscapular temperature, and were significantly higher in the OAGVP group. This was also taken together with the higher expression of PGC1 alpha. Everything suggests that the higher body weight is also associated with an increase in energy expenditure. Regarding metabolic parameters, the insulin was lower in this group of rats as well, and also the HOMA index. To assess whether the metabolic improvements could be due to hormonal changes, we measured total ghrelin and also its both isoforms, desacylghrelin and also acylghrelin. And we found that the levels of desacylghrelin were significantly lower in this group of rats. And also the correlative analysis showed that there was a direct and significant correlation between this isoform and the levels of insulin, HOMA-R, leptin, and adipo index. So this association suggests that a reduction in circulating desacylghrelin levels lead to an improvement on the metabolic profile. So in summary, the OAGVP group of rats show higher weight loss that with a similar food intake, it was due to a lower food efficiency ratio that was caused by an increase in the thermogenesis that we observed by an increase in the PGC1 alpha. The metabolic parameters were also better in this group of rats, and this was maybe related with reduction in the desacylghrelin. Based on the previous findings, we designed another study with the aim of consolidating the identified mechanisms using a different surgical technique. We compared a primarily restrictive technique with fundus removal, like the sleeve gastrectomy, with a technique that combines fundus resection with an hypoabsorptive component. The experimental design included 56 Wistar rats, and 46 of them were fed for 16 weeks with a high-fat diet, and after that they were randomized into receive SADS, sleeve gastrectomy, sham surgery, and another group was a control group that continued with a high-fat diet. 6 weeks after randomization, rats were also sacrificed, and we also measured blood samples, adipose tissue, and we also measured energy expenditure. Final body weight in the rats submitted to studies was significantly lower. As we can observe here in this graph, body weight was decreased in the first 2 weeks in the sleeve gastrectomy and also in the SADS, but after that time, sleeve gastrectomy rats regain weight, and on the other hand, SADS rats keep losing weight. This was also associated with significantly lower levels of total adiposity fat depots, epididymal, subcutaneous, and also perirenal, and the adipocyte size was significantly lower also in this group of rats. Indirect calorimetry showed that rats submitted to sleeve gastrectomy had a higher production of CO2 without any differences in the consumption of oxygen. So that suggests that the respiratory quotient was more close to 1. That talks about a predominant carbohydrate oxidation. On the other hand, rats submitted to SADS had lower levels of CO2 production that with a similar consumption of oxygen. So their respiratory quotient was more close to 0.7, with that reflecting a shift in energy substrate utilization towards a predominant lipid oxidation. So as we can observe here, the rats submitted to sleeve gastrectomy had a higher glucose oxidation, and the SADS higher lipid oxidation. So SADS induce a qualitative shift in energy metabolism, favoring the use of fat. Regarding metabolic parameters, rats undergoing SADS had better levels of glucose, insulin, HOMA-R, Quickie index, and also triglycerides, cholesterol, and adipo index. And they also showed a significantly higher adiponectin-leptin ratio. Finally, we measured some key regulators of adipose tissue metabolism, and what we found is that it was that a significant increase in some genes related with the adipogenesis of the brown adipose tissue. We also observe a significant decrease in the expression of UCP1 in the brown adipose tissue, and taken all together, we can conclude that there is a qualitative improvement in brown adipose tissue function and the metabolic regulation. Measuring the genes in the white adipose tissue, we observe a significant increase in the UCP1 and also a significant increase in other genes that talk about the browning of the white adipose tissue. And finally, in the base adipose tissue, the increase in the genes suggests that there is an enhanced identity of the base adipose tissue. So summarizing all the study of the genes, we can conclude that the SADS creates an adipose tissue reprogramming, creating a more competent brown adipose tissue and favoring the browning of the white. And then translates into a fat mass loss and also a metabolic improvement. So, in summary, bariatric surgery induces hormonal changes that help regulate energy balance and improve metabolism. These effects go beyond restriction and malabsorption and also involve important hormonal and metabolic adaptations. OGBP benefits with a combined action of hormonal, thermogenic, and hypoabsorptive mechanisms. SADS promotes adipose tissue remodeling toward a more thermogenic and metabolic activity phenotype, whilst sleeve gastrectomy has a more limited effect. And in diet-induced obese rats, SADS achieves greater weight loss and metabolic improvement, mainly increasing the fat oxidation. So thank you.
Thank you very much. Are there any questions, please?
Hello, nice paper, nice research. 2 questions. Sorry about my ignorance, but when you say 4 weeks in rat years, we're talking about what kind of time?
4 weeks in rats is like 1 year, more or less
1 year?
for a human. Yes.
Okay. When you did the work on WGB, you did 4 weeks, and then when you're doing the studies, you're doing 6 weeks. Was there any reason for that?
No, we wanted to check to compare the weight evolution between the sleeve gastrectomy and the SADS, so that's why we waited a bit more to analyze the results, but it wasn't. No.
Okay. About the browning of the liver, the lipid oxidation, you did not compare that on the WGB. You're on sleeve.
No,
and
we only
SADS.
measure it with sleeve gastrectomy and SADS because making an indirect calorimetry is complicated, and we couldn't do it on the other group of rats. It wasn't
Okay. It
possible.
was a shame. It was really nice. It's really nice to see you on rats, what we see most of the times in patients, but we don't have so much data as you have right here with the mice. Yeah, nice one.
Thank you.
Thank you very much.
Can you use the mic?
Just short, I think, would you speculate about the discriminative results in high protein diet comparing high fat diet?
Excuse me, could you repeat because I didn't hear?
You use high fat diet.
Yes.
What would happen if you change to high protein diet?
To high what?
Protein.
High protein, sorry. No, we use high fat diet to induce a model of exogenous obesity, and that's why we use the high fat diet. Yes.
Okay, thank you. It is my pleasure to introduce next speaker from Germany, Dr. Carolina Papa-Keller. She's going to talk about metabolic and bariatric surgery in muffled. The floor is yours.
Thank you very much for this kind introduction, and I'm very proud to let you know a little bit about our recently published review about metabolic and bariatric surgery in muffle D. So these are my disclosures. And while talking about muffle D, we talk about a disease with a prevalence between 25 and 44% all over the world, and with a growing progress. And if we see this data here, we talk about a global adult prevalence of 38%, and if we see the type 2 diabetes patients, we already talk about 65%. So muffle D is much more than a fatty liver disease. We heard that already, and it is one part of the systemic metabolic inflammation progress in the bodies of our patients. And without treatment, there is a continuing progress of this disease over MASH and over cirrhosis, and it leads to earlier death. The BRAVES trial had shown in a randomization concept by one, the normal lifestyle intervention and best medical care therapy versus the Roux-en-Y gastric bypass and versus the sleeve gastrectomy. And in those 288 patients in a 12-month control, they could show that with 56% and 57%, the surgical groups showed NASH resolution compared to the intervention with the best medical care and lifestyle, 16%. And also the fibrosis improvement was significant higher in the two surgical groups. And it was quite a good safety profile, so it seems that the surgical procedures are quite a good idea for our patients. But, well, we have the problem, we're talking about high-risk patients. We have a very good surgical solution for the disease, and on the other hand, we have high-risk patients, and of course, we want to know if metabolic surgery in muffle D patients is a balancing act. So the aim of our study was to define the risk-benefit threshold for MBS in patients with muffle D. We conducted a systematic review in a PRISMA-based research in 5 databases in a 15 years period. 29 studies were included and almost 72,000 patients from 14 countries. Our patients were biopsy or elastography confirmed MAFLD patients undergoing bariatric procedures of different kinds. The data collection consisted of the liver status, fibrosis, cirrhosis status, portal hypertension, child puke score, and MELD score, the metabolic profile, surgical procedures, outcomes, and complications. And we conducted a meta-analysis in MASH remission, fibrosis remission, diabetes remission, and the complications. The minor complications were defined Clavien-Dindo 1 or 2, and major complications were defined Clavien-Dindo more than 3. And now I'm going to show you the box plots of our meta-analysis. The MASH and MAFLD remission was 70%, and at this point I have to say MASH and MAFLD because we all know it's not the same disease. But in our review we had to find that there was a great heterogeneity in definition of those diseases, unfortunately. And well, also you see a heterogeneity in our results, and we showed 99% heterogeneity, so that's why we use the random effects model. You see a slight difference between the two surgical groups, 69% of remission in the gastric bypass, and Roux-en-Y gastric bypass, 71%. So the fibrosis remission was overall 57%, and stratification by cirrhosis showed it 59% in the compensated group, and in the decompensated group 51%. 51% in a decompensated patient is definitely not a normal number. So what we found in our study is that those patients with a decompensated liver disease undergoing bariatric surgery were operated either in a bridging to transplant setting or in and therefore in very high specialized centers. The diabetes remission rate was 59% with sleeve gastrectomy, with 54%, and Roux-en-Y gastric bypass 69%, and the complication rate was 15%, an all-over complication rate, with major complications being 4%. And here you see one study with a very high complication rate of 100%. This depends on the study itself, because this was a retrospective study only looking at those patients with complications. So the global findings and limitations of our study were: there was a negative association of cirrhosis status and fibrosis remission. The decompensated liver disease had a higher risk and a reduced chance for improvement, and endocrinological instability showed a higher risk also in those patients. Heterogeneity across all studies were the outcome definitions, I already said that. The diagnosing remission, some said, okay, we're going to do a biopsy-proven diagnosing. The others were only doing it by imaging, so it was quite heterogene. And also in the reporting of the liver-specific parameters and the MELD score and the child puke score. So the risk calculation that we can adapt from this paper, we would say decompensated liver disease, red flag for normal bariatric centers, especially if there is a portal hypertension, but of course in a transplant, bridging to transplant setting in a high specialized center, this might be a solution. Well, orange maybe for the fibrosis state 2 to 3 and stable patients, they can, if you treat them before surgery and if you do a prehabilitation on those patients, they can really pass in a very good quality the surgery. But of course, they need some preparation. But easy to treat patients with bariatric metabolic surgery are controlled metabolic and liver disease patients with a child puke score of 8 or a MELD score lower than 10. So bariatric surgery in MAFLD patients is not a balancing act if we select the right patients. So thank you for listening this afternoon, and I want to invite you all to Munich and hope to see you there.
Thank you very much for showing us these impressive results of surgery over the MAFLD disease. And I know this was not the topic of your meta-analysis, but do you think that now with GLP-1 agonists there can be a change in the treatment of the MAFLD? Do you think that for patients with decompensated liver, at least
yes,
we could...
I think that's a very good option for our patients. But of course, we need studies, and then also we have to compare, ideally by randomized trials.
Okay, and in decompensated liver, you will not recommend any kind of metabolic bariatric procedure? I mean, even endoscopic or just a sleeve?
I think endoscopic could be discussed, but patients with portal hypertension might be challenging with gastric varices if you don't see so perfectly maybe what you're doing with your stitches. So I don't know, it might be challenging, but this would be a question to be asked to the endoscopist.
Thank you. Is there any question? Oh. To the mic, please.
Thank you for your excellent presentation. My question about it: when patient is obese person and have diabetes mellitus type 1, and your opinion, you prefer for of type surgery, sleeve gastrectomy or bypass?
For patients with diabetes,
Yeah.
Well, in my opinion, patients with diabetes go better with a bypass because of the duodenal exclusion with all the effects on GIP and GLP-1.
That's my question about MAFLD and MESH. It's a chronic disease. After sleeve gastrectomy, if a patient have weight gain, and maybe it's not enough to improve liver condition. That's why.
I think I didn't really get the question right.
When patient has liver disease, that's MESH and MAFLD, and the patient after a sleeve gastrectomy, later 5 and 3 months later, maybe have weight gain. It's not a good decision before we takes on gastric mini bypass or IGP. What do you think?
Well, I think this could be a good option to transform the sleeve gastrectomy before this patient gains weight again too much. Don't wait too long, because then the disease will be
Started again.
Yes, of course, and then it will be even more difficult to treat the patient.
Yeah.
Thank you very much again.
Thank you.
Okay. Our last presenter is Dr. Sergi Sanchez Cordero, and she's going to present us SADS versus one anastomosis gastric bypass, 12-month results of the OASIS trial.
Well, good afternoon, everyone. I'm not Dr. Sanchez Cordero because he cannot come here, but I'm one of their team, Dr. Ruth Lopez from Spain, and I'm going to show you our results about the OASIS trial. I have nothing to disclose. So first of all, SADS, as we know, is a bariatric technique described in 2007 by Dr. Sanchez Pernaut and Dr. Torres, like a simplified variation of the DS. It has only a single anastomosis, so it's an easier technique than DS, but it keeps the good results about weight loss and comorbidity resolution. It has been approved in 2020 by American Society and by IPSO.
And on the other hand, we have OGB. OGB is a bariatric technique, so described by Rutledge in 2001, posterior modified by Carvajo, and it's a variation of a gastric bypass that includes only one anastomosis. It has been approved by IFSO and American Society too, and it keeps the results, even improve the results of gastric bypass, but simplify the technique. So we decided to compare these two techniques because they have some similarities, because they have just one anastomosis, and both techniques are powerful bariatric techniques. So we decided to design the OASIS trial. The OASIS trial compares OGB with SADS in cases of BMI between 45 to 50. And in this presentation, I'm going to show you our 12-month outcomes. So, as we said, it's a single-center, prospective, randomized, single-blind clinical trial. It has been approved by Ethics Committee, and it's registered. And we calculate the sample to get results, and we include a total of 87 patients. The inclusion criteria was patients between 18 to 65 years old with BMI between 45 to 50. The exclusion criteria were criteria along contraindications to metabolic or bariatric surgery or laparoscopic surgery, or patients who have an indication for a two-stage surgery, or some contraindication for malabsorptive metabolic bariatric surgery. So in this presentation, I'm going to show you the results about the 12-month outcomes, but we have published the results of short-term safety, that is the 30-day results. I'm not going to explain all the paper because I don't have time to do everything, but on this paper, on the previous analysis, we see that there were no difference in baseline characteristics between the groups, so the randomization was correct. And we see that SADS showed a longer operative time than OGB with a higher overall complication rate. Short-term complication rate, only 30 days. So severe complications and reoperations were higher in SADS, but not statistically significant. So the conclusion was that maybe OGB offered a more favorable short-term safety profile on 30-day results. So now, yes, I'm going to talk about 12-month outcomes, and we start with weight loss. In terms of weight loss, about BMI at 1 year, total weight loss and excess weight loss, we didn't find any difference between groups. So the weight loss was correct in each group, but we didn't see any significant difference. About comorbidities, we analyzed hypertension, diabetes, dyslipidemia, and obstructive sleep apnea, and we didn't find any difference between groups, between SADS and OGB. And both of the groups have good taxes rates of improvement or resolution. And here on the complications, we see the difference. On SADS, we have 3 complications, late complications. All of them were with a Clavin-Dindo over than 3B. There was 2 cases of one of perforated anastomotic ulcer that requires reoperation, 1 complex incisional hernia because of the SADS that requires reoperation too, and 1 death that I will explain later. On OGB, we found 17 complications, but there were less severe than SADS. All of them were related to bile reflux. 1 case is found on the endoscopic gastroscopy, we found eosinophilic esophagitis, 10 cases of bile reflux, and on 5 cases we found an anastomotic ulcer related to bile reflux. Any patients need reoperation, and all of them requires medical treatment. So if we compare the complications between groups, we found that it was higher in OGB, significant higher. About nutritional deficiencies, we see that we only found 5 patients with iron deficiency, 3 in SADS and 2 in OGB, but it was not statistically significant between groups. All the patients, the 5 patients, require iron supplementation. And the case of mortality that I have said before, it was in SADS group. It was a patient that have a nosocomial pneumonia and needs to ICU stay and needs a tracheostomy, and during the exchange of the tracheostomy cannula, he had a cardiorespiratory arrest and he died. So the conclusions of the 12-month outcomes that we get about our trial was that SADS and OGB achieve comparable weight loss and metabolic outcomes at 1 year in patients with BMI from 45 to 50. But we see the difference in complications. OGB was associated with higher rate of bile reflux events, but SADS showed more severe complications. All of them requires reoperation. So we need more follow-up to get more conclusions about these surgeries. So thank you for being here.
Thank you for presenting this marvelous study. I have 2 questions. One of them is, you have more reoperations rates in SADI group, but there was more bile reflux in the OAGB. So what was the reason for this reoperation rate in SADI? Because we normally don't accept so much. It was like proximalization or because of complications?
Yes, it was because the complications. It was a perforate ulcer, a complicated hernia.
Okay.
So we have these 2 reparations.
And you don't have conversions from OAGB to Roux-en-Y, right?
No, okay. This is the results of the first year, so
first year.
Not yet.
Okay. And the second one is, how was your limb lengths in the limb lengths in the SADI and also in OAGB?
In SADS we use a common channel of 300 centimeters from the ileocecal wall, and OGB we use 200 centimeters from threads.
Okay, so it was a standard in the study. Right?
Yeah.
Okay. Thank you. Are there any questions from this? Yeah.
Just concerning about the pre-op evaluation, what kind of pre-op evaluation you did on the SADS and OGB? You did endoscopy? Endoscopy, upper GI endoscopy involved.
Previous of the
previous,
surgery?
no esophagitis, all
no
of that.
esophagitis
No
in
kind
all
of
cases.
reflux syndromes, reflux symptoms?
No. These kind of patients doesn't include to the trial.
Did you guys, you said that you had 3 meters common channel on the SADS and 2 meters of biliary pancreatic limb on the OGB fixed. But did you guys counted all the bowel, or was just...
we didn't count all the bowel.
The bowel. Okay, thanks. That's all my questions.
Do you take into account the patient quality of life outcomes? Do you look into quality of life outcomes?
Yes.
Or complaints, for example, reflux complaints? Or?
Yes, we pass, I don't know how to say in English, some questionnaires at 1 year, 2 years, 3 years, but I didn't put him there. But we assess the quality of life after the techniques.
And there was any difference?
No.
Okay. So is there any question, comment from the floor? No? Thank you.
Thank you.
So it was a pleasure to spend this afternoon with you. It was a great session. Thank you very much for being here, and thank you very much, Ellen.